Good morning, everybody. Good to see you all, and thanks for joining us today. Just really want to start uh, this morning by noting that yesterday was the 7-year anniversary of the SR 530 landslide. And it was really a disaster that struck at the heart of the Stille Valley and our county and took 43 lives. And I remember the day well when I got the phone call from our emergency management director that there had been an event out there, and had no idea the magnitude. But we really need to remember here in Snohomish County and across the region all the losses that were suffered, and we must not forget them. It really showed us that in times of need, people come together and people come to our aid. So we remind ourselves every year that there's a long road to recovery, and we also need to remember and honor our losses. But we also need to remember that from that tragedy came partnerships and experiences that have really helped us be better prepared for the COVID-19 pandemic. Our emergency management system was stood up for quite some time during the 530 landslide event, and frankly, it was stronger after that and for that. So we just want to remember those losses and honor them, and be grateful for being better prepared because of them. So we're starting to see the horizon, I hope, on this pandemic. We continue to vaccinate more people every day, and we are advocating at the state and federal level for more vaccine to come from the state and federal government. Yesterday, we entered phase 3 of reopening, and by the end of the month, many more people will be eligible for vaccines. So that's all good news. We do have a ways to go, and I know Dr. Spitters will be addressing this here this morning. Our long-term care facilities also are starting to see visitors again. And I spoke with leadership at Providence yesterday, and while they're still seeing cases, they're seeing fewer critical care cases. So that's good news. And we just really want to keep that progress going. We're not going to be able to enjoy regular rhythms of life for some time, but we are making progress, and I think everybody can sense that. Just in mind, being mindful of all those we've lost to COVID-19 and all that are still at risk, we really have to stay strong and diligent about wearing masks and keeping our physical distance and being careful. So we're not through this yet. We're making good progress, but we really come too far to let down our guards. So I urge everybody to continue to be safe, wear your masks, be careful. We're not through this yet. We've got a ways to go, and we don't want to turn around now and turn around our progress. So with that, I'll hand it over to Dr. Spitters from the Snohomish Health District.
Okay, make sure I'm unmuted. Thank you, Executive Summers. Good morning, everyone. And just get my visual set up here. So today I have a few slides with numbers and images that I'd like to share. So I'm going to share my screen here for just a minute. Okay. And so this shows our rolling 2-week case rate. You can see it came down in sort of 2 phases. First, very rapidly there through January and early part of February, then sort of a slowing of decline, which is expected. But now we've kind of, it looks like maybe we bottomed out. Through Saturday the 13th, we were at 70 cases per 100,000 per 2 weeks. And then through this past Saturday, the 20th of March, similar figure, 72. So, you know, flat at best, maybe a slight uptick. Statewide aggregate counts show a similar plateauing of case rates in recent weeks, and King County data also shows a slight increase over the recent weeks. So moving into phase 3 and expanding occupancy and activities is great news for all of us. But we also want to stay in phase 3 and continue to progress. So that means we need everyone, as Executive Summers mentioned, vaccinated or not, to keep up the prevention measures. I know people are tired of COVID. I certainly am, and the team at the health district, although we stay on it every day. It's been a long haul for all of us and for all of you, but we're getting close, but we're not there yet. Until then, we really need to keep up with the 3 Ws: wearing a mask, watching your distance, and washing your hands. And I'd throw in a V there too, V for ventilation. When you're indoors with folks that aren't from your home, keep the windows, doors, screen doors open. When you're riding in a vehicle, crack the windows at least if weather permits, keep them open, keep the air moving. So to that point, I want to bring up one area where we've seen a growing number of cases in recent days, and that's in sports settings, in schools in particular. Um, Within the last week, our school outreach team has investigated at least 6 cases that played or practiced on school sports teams while contagious. Since the beginning of the year, we've had cases associated with numerous sports, including football, volleyball, soccer, swimming, basketball, hockey, and softball, as well as general weight training. And you know, as sports move from outdoors to indoors, that's riskier, as well as when competitors or practicers, participants are close together. So keeping things outside and spread out is best. And schools, teachers, and students are doing a great job with prevention measures in the classroom. And we also think that players, coaches, and families are doing that outside the classroom, particularly on the playing field, on the court, etc. But the impression we're getting from these contact investigations that have followed these cases and their contacts is that like findings from elsewhere around the country related to sporting outbreaks, it's often that the breakdown in prevention is happening amongst teammates off the field or court. For example, in locker rooms, on the bus, or in a carpool to and from games, congregating and talking without masks in the parking lot, when breaking for snacks or water, and get-togethers, social get-togethers outside of the sporting event itself among teammates. So just a reminder that those are all areas that you got to keep up your guard 24/7, 100% of the time with your teammates and fellow participants. Masks should be worn when you're around people you don't live with. Spread out in a bus, limit carpools when available, keep the windows cracked. Wash your hands, use hand sanitizer frequently, as well as sanitizing high-touch surfaces like door handles, seat belts, steering wheels, cell phones, and in sports, the equipment that's being used. So I want to move on to our next slide. One last piece on some data, and that's updates on how often we'll be releasing some data components moving forward. Starting next week, we'll be scaling back the reporting of new cases from daily to weekly. The daily counts, especially the first day or two that they come out for a particular date. So today's accounting of yesterday's reported cases is incomplete and essentially meaningless. We don't really see those numbers stabilizing for several days to a week anyway, so they're kind of meaningless. So in order to permit our staff to focus on higher order priorities, we're just gonna do that once a week. And those will now come out on Mondays along with the weekly case rate, what I just showed you. And next to those on our website on the case count page are hospitalizations, long-term care, and mortality rates that'll all continue to be updated once a week. The bi-weekly, every 2-week reports and maps that we've been doing, those will now move to monthly. We're just not seeing actionable changes on the 2-week timeline to merit the investment of the epidemiologist's time when there's other things like some of the vaccine work that we want to focus their time on. So that'll be slowing down, but not stopping. And of course, we'll be keeping an eye on the numbers all the time. And if something occurs between a report that has disease control significance for the community, we'll certainly bring it up and let you all know. The rest of the reports and graphs will remain as is. Moving to talking about changes, moving to testing. We announced last Friday in our press release that the original testing site operated by the Health District on Broadway in Everett will be moving later this week. Today, March 23, in addition to the anniversary of the Oso landslide that Executive Summers mentioned, also marks 1 year since our site at that 3900 Broadway testing facility opened. Little did we know we'd still be here a year later. We're deeply grateful to Everett Public Schools for allowing us to use its lower parking lot at their headquarters and for its continued support with new testing. As the county moves into phase 3 and spectator events are permitted, the Health District needed to move this test site near Funko Field so that Everett Public Schools and the Aqua Sox have parking for both the stadium, Memorial Stadium, and Funko Field. Our last day of operations at that site will be this Thursday, March 25. And we're grateful that the school district is allowing us to use another property nearby, also known as the Longfellow Annex, beginning Friday, March 26th. That's located at 3715 Oaks Avenue in Everett. Okay, last I want to just make some comments about vaccines. On the vaccine front, we continue to make progress with promise of further progress in the future. Through last week, 188,000 Snohomish County residents, that's 23%, had initiated vaccination, and 110,000 or 13% had completed vaccination in the 3 months since efforts in that direction started. And that's there we're using the entire county population of 830,000 to say 23% started, 13% finished. If we look at specific eligibility groups, it's much better than that. For instance, among adults over 65, about 2/3 have initiated, and I think about 35 or 40% have completed in that highest risk group that's at the front end of the vaccine priority list. Even with improving supply, as we're seeing, it will take quite some time to get Snohomish County fully vaccinated. Our goal remains to achieve complete vaccination of all eligible individuals who want to be vaccinated. Applying national estimates suggesting that up to 80% of adults either definitely or might want to be interested in getting vaccinated, then a target figure of about 600,000 adults represents 90% saturation of that group of adults definitely or may be interested in getting vaccinated. So moving toward that 600,000, which is not the end of the effort, but it's a milestone that we're trying to achieve. The speed at which we make progress is largely dependent on supply, given that our current administration capacity through the county's mass vaccination sites and other vaccine providers exceeds the supply. Looking at future allocations, between state allocations to providers like the health district, the mass sites, and then community clinics and other healthcare facilities, and adding in federal allocations directly to retail pharmacies that don't go through the state or the county, they just go straight to local pharmacies, we can anticipate almost 50,000 doses coming in weekly over the coming months, and with some promise of further increases coming from the governor and the federal government in comments in the last week or two. So at that pace, we would reach that target of 600,000 fully vaccinated adults by approximately mid-August. So roughly 5 months from now, 4 to 5 months from now. If the supply is less, say 35,000, for instance, this figure I calculated, assume that we get 10,000 doses of Johnson & Johnson vaccine coming in over the long haul. We're not getting those yet. We got a little bit in the beginning of the month, none for the rest of the month as the manufacturers building up supply and distribution, but we should start seeing that again in May. But let's say that didn't come, just as a scenario, and we're down around 35, 36,000 doses per week. Then our target figure of 600,000 fully vaccinated adults would not be reached until mid-October. And under a worst case scenario, let's say where all we had are the 25,000 doses coming to the county providers, and let's say the retail pharmacy program stopped. Retail pharmacies are currently getting about 10 to 15,000 doses a week directly from the federal government. Then it would take us out until the end of the year to reach that 600,000. So these are just hypothetical scenarios to give you an idea of the pace at which we can achieve our goals, given broad ranges on anticipated vaccine supply. But even under the best case scenario, this is going to take several months. So although all adults will become eligible for vaccination on May 1 in Snohomish County, Washington State, and the United States, it's going to take many, many months for us to get through all those folks. So again, we present this for three key reasons. As I said, to demonstrate what supply levels we need to get to in order to hit those national goals of all adults getting vaccinated by this summer, which is basically 50,000 plus doses coming to various settings in the county every week. We also want to help explain that timeline is why we all need to be patient as we wait to get a vaccine. Demand still far outweighs the supply. With right now, this week, we've got about 10 or 15 eligible candidates for every dose that's available. So that doesn't mean stop trying. It means keep trying, but be patient and know that your turn will come, even if it doesn't come this week, next week, or even the week after. If you stay in there each week, the odds of getting an appointment improve. And then last, but certainly not least, is to let folks know that we have some time before we're out of the woods here with COVID transmission. 25% of the population starting vaccination or 15% fully vaccinated is not enough to interrupt transmission substantially. So particularly with these new strains arriving and expanding their share of the amount of virus that's going around, and they're more transmissible, we really need to keep our guard up so that we can keep these case rates low, stay in phase 3, keep kids in school, and get through the next 4 to 6 months or possibly longer if supplies aren't good, without going through a big, wave number 4 with hospitalizations and deaths and all that we've been through before. With that, I urge and plead for your continued excellent efforts to reduce transmission in your homes, workplaces, and where you do get together with others. And so with that, I'll turn it back to Executive Summers.
Thank you, Doctor. And starting on the questions. So this one's for you. What is the update on variants in Snohomish County? How many and which ones are here? How many are right over the border in King County? And what is the data showing regarding these variants? Any changes needed in protocol for high-risk residents?
Well, so first, just to kind of go back before the present moment, once these appeared and the data from, particularly from Britain, was clearly suggesting increased transmission, it was predicted that this B117 would probably replace the dominant B1 circulating strain, which the B1 strain and its relatives are a variant from the original strains that arose in Wuhan. So we've gone through this multiple times, and this will increase as a proportion of total cases. In the month of February, the state lab did sequencing, DNA sequencing on about 6%, exceeding their 5% target, 6% of positive PCR tests collected statewide. And the number of B117 variants has gone through that. We got up to, I think, 7 detected in Snohomish County, several dozen detected in King County, a handful of the B1.135, that's the variant associated with South Africa, also increased transmission, and some concerns about immunity, its ability to escape immunity in the test tube, not quite as much with the vaccine. So those are all being seen. You can find that report on the State Health Department's website. And I think the key statement I close with on that is just that, as expected, we're starting to see these represent still a small but increasing proportion of cases. And over time, several months down the line, I think we'll see that play out. CDC also put out a report on this that shows nationwide that the proportion of cases associated with these strains is increasing. Oh, I'll just, one thing. No difference. All the measures still work. You just gotta, there's less room for error. So social, distancing, masking, keeping things outdoor, keeping things well ventilated, keeping your hands washed, all that will work. There's just less margin for error for slip ups. So that's the protocol for high risk and low risk residents.
So, Doctor, is the bottoming out of cases and the slight uptick any indication of a fourth wave, or do you expect vaccinations to overcome the uptick?
Well, we've now been through this several times. We know why and how it happens. And so it's really in our hands. So I'd say let's see how the next few weeks go and see whether we're able to keep that flat, or even better yet, further push it down, or are we going to have to sustain another increase and all the consequences associated with that? I really think it's in our hands, and it's hard to predict what the final score is going to be looking at the scoreboard at halftime, so to speak. But things aren't looking good, and the other team is catching up, so to speak. So I'd say it's time for us to really double down on all those efforts to at least keep things level and try to push them down further.
And Doctor, a point you made earlier is at the current level of vaccinations, though, we wouldn't expect that to be enough to really prevent another uptick. Is that correct?
I think that's right, Executive Summers. The range of estimates on what proportion of the population needs to be immune to interrupt transmission of the virus, also known as herd immunity, that percentage of the total population. Estimates have ranged from as low as 25% up to 80 to 90%, with the majority of them being up in that 75, 80% zone. So even if you add in all of the cases that have occurred and all the immunized folks, we're, at best around 25, 30% of the population with some level of immunity. And that's not enough to permit us to let our guard down.
Okay. And outside of youth sports, have you seen a significant increase in cases among younger demographics? And if so, can you provide any numbers on that? And what other factors would you expect to be contributing to a rise in younger cases, such as they've seen in Grant County recently?
Yeah, so through our last report, we had not seen increases in young adults, which, as you recall, in the prior waves 2 and 3, that was the leading edge of the pandemic in the community, were adults 20 to 39 years of age. King County, excuse me, the state of Washington has reported that they've seen a slight increase among that age group. We haven't seen it yet in our data analyzed through, that would have been the 13th was our last report. We'll have another report coming up here through the 27th that we'll release next week. I hope we don't see it, but honestly, I won't be surprised if we do, because it's happening elsewhere. I think this is probably a behavioral or activity related thing with younger adults, with the weather improving, maybe gatherings increasing for whatever reason, social, sports, what have you. Possibly, we'll see as phase 3 rolls out whether any of the occupational activity is leading to to some of this, although our outbreaks in workplace settings are way down off the peak and haven't started to come up. So, those are the two key ingredients, social, private gatherings and workplaces. That's where young people tend to be in close quarters with others. So, it is a call on all of us, but especially our younger adults, to try to endure and stick with the recommendations.
Okay. Another question regarding the plateau: is the flattening of the plateau considered a good thing because cases are no longer going up, or a bad thing because they're no longer declining? Could you elaborate a bit more on that?
Well, it's a fair question. Glass half empty, glass half full. I certainly want to. The further we can push things down, the more margin for error we have. Should these strains, prove to be more problematic, these variant strains that are emerging, if they prove to be more problematic than we anticipate in terms of severity or I guess I'm saying susceptibility to the immune reaction provoked by the vaccine, right? The lower, the better. It gives us more room. So, 70 is better than 100, 35 is better than 70. That's my goal. Let's keep getting it down.
Yeah, I guess from my standpoint, we obviously want to get back under 25, or hopefully someday to 0. And that's the goal. It's the level, and the leveling off is enough to cause concern and to remind us that the virus is still out there. It's still being transmitted. And if we don't keep our protective measures in place, it could easily go back up into another wave, such as they're seeing in, I think, over 21 other states in the US are seeing upticks, and places in Europe are seeing upticks. So we've just got to be careful. We got to keep vaccinating and kind of hold the line on this. I'd say the plateau is concerning. It's not a disaster yet, but it's just a reminder. Okay, can you address the possibility of adding the AstraZeneca vaccine to the supply, and whether you think that might help the county meet its capacity? And how about the effect of J&J now saying it might not meet the production level we were expecting?
Well, more vaccine is good. And if AstraZeneca gets approved and becomes available, then that adds to our supply, and it adds also stability. If the more products that are out there, then the less likely that an interruption in production or distribution of a single product is to wreak havoc on our overall approach. So, a broad portfolio of products on the market and available to us is a good thing, and it helps us manage the risks of those. So that would be welcome news. But the details on the timeline for that sort of thing are still in the hands of FDA and the manufacturer to work that through. But presumably they'll be applying for an EUA and get approved, and then CDC will make recommendations, and it'll move on just as it has for the other vaccines. A problem with Johnson & Johnson production or with distribution with any of the products is going to set us back a little. And as I said, the broader the palette of products we have available to us, the less susceptible our response will be. So. Executive Summers, you're muted.
Gosh, it's been a year now still. So there's a request to get the numbers of doses coming to the county this week in both the regular allotment and through the federal pharmacy program.
Okay, so we've been allotted, it's 26,000 doses will be coming to vaccine providers, including the mass vac sites. That's Pfizer and Moderna, no J&J. I can't give specifics on, that's just the allocation we've been that the county has been allotted, and the distribution of that within the county is still getting worked out. That gets worked out over the course of the week. And then the federal pharmacy allocation, we don't see that in real time for the current week. We always see the prior week. So 2 weeks ago, it was 11,000. Last week, it was 14,000. I anticipate it continuing to be somewhere in that 10 to 15,000 range going forward.
Okay. It seems like it's easier than ever to get the vaccine with new tools from the state plus the boosted supply. Is the August vaccine timeline perhaps conservative?
Mm, it's just dependent on supply, and then at some point, if supply became so great, then the rate limiting step would be our ability to administer it. You may recall back in the very beginning, we had more vaccine than capacity to administer. Now we've got more capacity to administer than vaccine. But I think 50,000 doses a week is kind of in the strike zone of what the federal government is telling us. If the supply is augmented, proportionally, roughly proportionally, if it's let's say it's 50% greater than we expect, and we end up getting 75,000 doses a week, and we're able to administer all those, it would roughly take 2/3 the amount of time. So instead of 5 months, it might be 4 months, 3.5 or 4 months.
I guess I just add that the scheduling system I know was frustrating earlier on, and it's getting better for individuals, but that was never the bottleneck in getting vaccines out. It was difficult on people to try to get an appointment, but we were able to deliver all the vaccines we're getting, and that remains the case. And we have the capacity to give more vaccine shots than we have vaccine, and that's been the case since day one. We expect that to remain the case. So the system's better, but that isn't really going to determine when we reach the 600,000 that were kind of our first goal, really. That's really, as doctors said, is dependent on how much vaccine we get and how soon. Does the Department of Health take any input from the county and health district when deciding who is in each vaccine eligibility phase, or does the county and health district find out when the public does? How hard has it been to plan when new groups are added to phases?
So yes, the department does seek the local health jurisdiction's input prior to finalizing its allocations. And how hard has it been to plan when new groups are added to phases? Well, it's on one hand, when we expand the eligible pool, the extreme of that will be on May 1st, when presumably all adults or everyone over 16 is eligible in the county. In a way, that simplifies things, right? Because you don't really have to figure out whether you're eligible or not. So, but what it does do is it increases the ratio of demand to supply. And so I think that's frankly, it's harder on those who are eligible, because as you become eligible, there's that's an uplifting thing, and there's hope. But the chances of you getting up to bat within the next week are not as high as they are in that compared to your chance of getting vaccinated sometime in the next 2 months, say. So I think that actually is a good thing, that we're trying to move through this quickly, and in a way, it really does simplify things. But it does make the ratio of demand to supply a challenge, because there's only so many slots right now per week, only so many doses per week. So I think that the harder burden of the acceleration falls on the consumers.
Yeah, I just say the thing that has made it difficult to plan is just not knowing how much vaccine we're going to get week to week. Each of these sites is staffed by volunteers, staffed by professionals. people have to be mobilized, and so it's very difficult if we don't know in advance how much vaccine we're going to get, whether we should stand up a site and should it be for 1 day, 2 days, 3 days, etc. So that's been the difficulty. The number of people that are eligible, less so. It is possible we could get overwhelmed with people sometime, but again, it's going to be the vaccine doses and the allocation that we have that's going to be the limiting factor and causes the difficulties. So you would think vaccinating the most vulnerable in the hospital system would really dampen the severity of a fourth wave. Is that correct? Doctor, I guess we'll leave it there and then get on.
Well, I think just, recent history shows that that vaccinating the long-term care facilities, in particular, the residents and the staff, which I think statewide, roughly about 90% of the residents uh, got vaccinated, about 2/3 of the staff. That has been enough to essentially eliminate, in the current moment, long-term care facilities as a key player in the pandemic. They account for about 20% of the hospitalizations and 50% of the deaths, almost all of those in the residence with a few staff. So, proof positive right there, the impact of vaccination on that. So for instance, if we had another wave now, I think the immunity from that would outlast that wave, and we wouldn't see. I think if nothing else changed, we'd see in that subsequent wave, if it was otherwise like the wave number 3, you'd see about 50% fewer deaths and 20% fewer hospitalizations. So it's an improvement, but it doesn't shut the door on the negative impacts of the virus on the community. And the other thing to keep in mind is that even among those who don't have severe disease now, as we look more and more and see data coming out about people who 3-6 months after having recovered still have difficulty breathing, short of breath going up the stairs, difficulty concentrating, and up to a third or a half of people who've had COVID. So it's really, we not only want to prevent the hospitalizations and deaths, but even just the cases because of the impact they have on individuals down the line.
So as more people get vaccinated, they're going to want to stop wearing masks in public, given they can in private. And then the second issue, excuse me, calls for vaccine passports are likely to rise. What do you make of the prospects of that? And let me jump in on this one just to start, because I get this question a lot about vaccine passports. And, growing up through my years, it was very common to have some documentation of vaccinations to travel around the world to different countries. That's not unusual. Has been common practice in the past, and I fully expect that to be part of our future, that many countries for entry or for travel will ask for documentation of vaccines. And I think it's probably more difficult and harder at a local level. We're not used to that, either within a state or across states, but certainly travel to Canada or Mexico, I would not be the least bit surprised, and I don't think it would be, really out of past practice to do so and asking for proof of vaccination. Doctor, do you want to add to that?
No, not really. I agree. I think you nailed it. It makes a lot of sense for international travel. It becomes a lot less clear in terms of effectiveness, enforceability, and equity. Whether it applies to going to restaurants. I'm not certain that we'll see it operating at that level. Yeah.
Any new data on vaccinations for kids under the age of 16? Is there a timeline for when the vaccination effort will move to that age bracket?
Nothing formal. There are clinical trials underway. I'm not really tracking those closely. I've heard in the popular press that, maybe sometime in the fall or the winter of 21, 22, we might be seeing that coming forth, but that's all I have on that.
Doctor, do you have a recommendation for play dates in younger age children? What is advised and not advised?
Well, I just follow the guidance. So, I'd have to think that through. We might want to come up with something more formal, but, if you're two households max, what is it, 5 or 10 people? I guess 10 people now in phase 3, 2 households max, 3 households. I'd have to check on the social gatherings part of that. Well, I think we'll get back to you, but the main idea is, while kids occasionally can have severe disease or that post-infectious mixed multi-system inflammatory syndrome, the real concern is who they're going to spread it to, even though they aren't really efficient transmitters, especially outside the home. So trying to keep it to 1 household or 2 households getting together at a time, I think, is a good idea. And if the older adults, if the adults in that home are vulnerable, I would think about that, think twice about doing that until those older adults of the participating homes have been vaccinated.
So last question on treatment, and especially for severe cases, is there a promising medication and or better outcomes in early in the pandemic? Such as, is there any talk of early treatment for high risk people with antivirals, early antivirals, etc.?
Well, remdesivir has a positive impact. It's partial impact. So it's not like, say, when you have a pneumonia and you get antibiotics, cure rates way above 90%. This is sort of like partial reduction in need for mechanical ventilation, partial reduction in death, so that people, if I end up with COVID in the hospital and I'm on oxygen, it seems this is a little bit out of my wheelhouse, but the data and the recommendations seem to say that corticosteroids to decrease inflammation in the lungs and the rest of the body, some anticoagulation to prevent clotting, and remdesivir to have antiviral effects. All of those, along with just the more experience in dealing with this infection in hospitals, better outcomes, less need for mechanical ventilation, less death, but not any elimination, or not even a reduction, say, by 50%. It's really the kind of thing like 10, 20, 30% reduction in various bad outcomes. So that's where we're at. So it helps. Folks who are hospitalized benefit from that, but it's not uniform in term, or 100% or anything really close to that. And just speaking to the best way to survive the COVID pandemic is to not get it. And so for now, that means prevention practices and vaccination.
I think that wraps us up.
This is Kristen in the Joint Information Center. Thank you again for joining us today and for all of your questions. We're going to go ahead and wrap up. Please stay tuned for future media availabilities.